Hi, everyone. So our poster is called Patient Views Regarding Cannabis Use in Chronic Kidney Disease, a Survey Study. Cannabinoids are used to treat chronic pain, chemotherapy-induced nausea and vomiting, HIV or AIDS, and pediatric seizure disorders. They're also used to treat mood disorders, sleep disturbances, and other symptoms, but their efficacy and safety in the setting of chronic kidney disease and dialysis is unclear. Regarding the aim of our study, we sought to elicit patient views regarding cannabinoid use across the spectrum of kidney disease, including chronic kidney disease and kidney failure, including hemodialysis, peritoneal dialysis, home hemodialysis, and transplant. Regarding methodology, the design of the study was an online and in-person survey. Participants included English or French-speaking Canadian adults with chronic kidney disease or kidney failure. The survey was circulated online via websites including Canadians Seeking Innovations and Solutions to Overcome Chronic Kidney Disease, which is a strategy for patient-oriented research for kidney disease in Canada, the Kidney Foundation of Canada, the Canadian Nephrology Trials Network, and kidneylink.ca, and their respective social media platforms, including Twitter, Facebook, and Instagram, and that was in the summer of 2020. We had to pivot to in-person recruitment because of poor response rates, and this utilized postage paid envelopes in winter 2021 at 7 sites in Canada. This included Seven Oaks General Hospital in Winnipeg, St. Joseph's Healthcare Hamilton in Hamilton, the University of Alberta Hospital in Edmonton, St. Michael's Hospital in Toronto, Queen Elizabeth II Health Sciences Centre in Halifax, L'Hôpital Maisonneuve-Rosemont in Montreal, and L'Hôpital du Sacré-Cœur de Montréal in Montreal. We collected participant demographics and previous cannabis use, including the type of cannabis, frequency of use, prescription status, indications, and healthcare provider awareness. We then asked to what degree a participant would consider trying cannabis for better symptom control in a clinical setting for each of the 10 following symptoms: anxiety, depression, restless leg syndrome, itchiness, fatigue, pain, appetite stimulation, nausea/vomiting, sleep, cramps, and other. Response options were categorized using a Likert scale ranging from 1 to 5, with 1 being definitely would not, 3 being undecided, and 5 being definitely would be in favor of trying cannabis for symptoms. All participants received every question, and answers were required to all questions. All responses were anonymous. We performed a complete case analysis without any imputation of missing data. We performed descriptive statistics to characterize survey respondents. We then used multi-level, multivariable linear regressions with individual questions regarding symptoms clustered in respondents to determine independent predictors of the likelihood of supporting cannabinoids for symptoms in a clinical setting. All variables were forced into the final model, including age, gender, province, type of kidney disease, previous cannabis use, and each individual symptoms as a fixed effect, with the intercept as a random effect, and we didn't include any interactions. All statistical tests were performed at a p less than 0.05 level of significance. Table 1 shows the characteristics of the survey respondents, and we had a total of 320 respondents. Over 90% was in-person recruitment, and the majority of patients were over the age of 50, with more than 85% or so being greater than the age of 50. We had 40% female respondents, and this is in line with the prevalence of CKD and dialysis in female versus males across Canada. We had the majority of recruitment, almost over 75%, from Ontario, Manitoba, and Nova Scotia. The response rate varied dramatically by center. It was highest in Manitoba at 33% and lowest in Alberta at 8.5%. These response rates were for the in-person recruitment only. Regarding the type of kidney disease, the majority were in-center hemodialysis, so more than 75%, with about 10% chronic kidney disease respondents, with very little representation from home dialysis, transplant, or other types of kidney disease. This is consistent about in-person recruitment from dialysis units during COVID-19. And about 50% of the cohort, so 160 people, had previously used cannabis. So figure 1 shows the route of administration of the cannabis in the previous 160 users. The majority had only used cannabis over a year ago, and mostly trying smoking, oils, or edibles. If we looked at more habitual use, including every day in the last week or in the last month, the most common types were smoking or oral roots, including oils or edibles. Figure 2 shows the reasons for non-prescription cannabis use in the cohort in the 160 patients. So the most common, which is more than 50% of those users, previous users, was for recreational purposes. The most common indications otherwise were for pain, sleep, and anxiety. And then less common indications were restless legs, depression, appetite, nausea, vomiting, fatigue, itchiness, and cramps. Table 2 shows the multivariable model of the likelihood of trying cannabis for symptom control. So independent predictors included symptom type, online response versus in-person response, province, with Manitoba and Nova Scotia being higher than Ontario, which was reference standard, and then previous cannabis use compared to no previous cannabis use. Age and type of kidney disease were not independent predictors in the models. Looking at individual symptoms compared to anxiety as the reference, appetite had a lower likelihood of trying cannabis for symptom control, whereas restless legs, pain, and sleep had a higher likelihood of trying cannabis for symptom control. Figure 3 shows the likelihood of trying cannabis control for all symptoms. So the mean, point estimate and 95% confidence interval for all 10 symptoms are shown and are all between 3 and 4, which 3 being undecided and 4 being probably would. So there's some degree of support for all of those symptoms. Again, pain was the highest, then sleep, and then restless legs, but all of them, as I said before, are between a 3 and a 4. So in summary, in our survey across Canada that had in-person and online response across the spectrum of kidney disease, about half of Canadian adults with chronic kidney disease or kidney failure had previously used cannabis, and it was mostly the following routes of smoking, oils, and edibles. The most common reason for previous cannabis use was recreationally, but also pain alleviation and for sleep. When we asked if they knew about, or if participants had reported their use to their physicians or if they were aware of it, only 1 in 3 had actually responded to this. When we categorized people, respondents into individuals that definitely would or probably would, so greater than a 5 or a 4, we found that more than 50% would try for symptom control for the following symptoms. So anxiety, depression, restless legs, itchiness, fatigue, pain, appetite, nausea, vomiting, sleep, or cramps. The characteristics independently associated with interest in trying cannabis for symptom control were symptom types, so pain, sleep, and restless legs had the most support. Online respondent, province, specifically Manitoba, Nova Scotia, and previous cannabis use. The study is limited by its relatively poor response rate in person. This is due to competing interest and potentially lack of interest in research, especially during COVID-19 pandemic, the potential for responder bias, and the lack of detailed qualitative interviews to discuss disease experiences and concerns about cannabinoid use in clinical settings or for research, and the lack of provision of detailed information about the benefit risk of cannabinoids for individual symptoms and individual side effects, and the opportunity to discuss this with healthcare providers. We just want to thank the Center for Medicinal Cannabis Research at McMaster University for funding this research, and to all the patients who participated in the study either online or in person. My contact information is located below, dtcollister@gmail.com, and you can contact me on Twitter. My handle's there as well, or you can also contact Dr. Walsh, who also worked on this study together. Thanks so much.